Yes, welcome, dear colleagues and friends. This is a webinar with the title Therapeutic Options for Sickle Cell Disease in 2019. And this is under the auspices and organization of the International Academy for Clinical Hematology, IACH, and I'm very grateful to them for allowing me here to present our results and in particular an overview on sickle cell disease in 2019. For any questions, please use the question mark button. I will try to answer your questions by the end of the webinar. And if you have any further questions, I can be reached anytime at selim.corbacioglu@mac.com. Now, before we go into the details of sickle cell disease, and in particular stem cell transplantation and other curative options, I want to ask the following questions that need to be answered in the next 45 minutes and of course during our clinical approaches in the daily basis. So number one, whom should we transplant? Number two, if we decide to transplant a patient based on his clinical condition, when should we transplant him? Number three, gene therapy. Is that now the choice? Is it en vogue or something? Is it something that will disappear? We will see. Or should we just stick with conventional care, as many hematologists and general practitioners out in the field prefer to do with these patients because they're scared of gene editing and gene therapy, and in particular also of all the negative consequences they have learned somewhere on stem cell transplantation. Now let's start with conventional care. Should we use conventional care or curative approaches, stem cell transplantation or gene editing? Now, in developed countries, different from developing countries and low middle income countries, sickle cell disease is not the classical presentation of vaso-occlusive crises and so on. It is a disease of chronic vasculopathy because different than in developing countries, 99% of infants will survive their 5th birthday. That is depicted here. So Lancet nicely published in 2013 that over the last 25 years, there's a decline in infant and childhood mortality. But at the same time period, mortality in adults, patients beyond 19 years of age, was on the rise. Hassel in 2010 nicely showed that we learned to cure these patients of sickle cell disease at young age. But at the same time, the only thing that happened is that this exponential mortality rate in sickle cell patients is rising, and this rise was shifted only by about 15 to 20 years. So the majority of patients still are dead by age 65 and 70. So there's no improvement of adult life expectancy. And when you look at the mortality reasons in sickle cell patients, it's not acute chest syndromes and it's not really strokes. The majority of those patients succumb to acute or chronic cardiac complications and pulmonary hypertension or cardiopulmonary failure, followed by thromboembolism and renal failure. So it's a completely different disease that apparently seems not to be cured by conventional care, such as hydroxyurea, exchange transfusions, blood transfusions in general. This is depicted also here by Tyne et al., who clearly showed that despite all the improvements over the last decades, National Sickle Cell Act, preventive penicillin, hydroxycarbamide, and transfusions for stroke prevention, the overall survival of sickle cell patients is on the rise and the life expectancy is on the rise, but it is still lagging far behind all Americans. And this was also updated in 2019 by Michael DeBon's nice presentation comparing now the median survival for adult sickle cell patients compared to African Americans living in the United States, that their life expectancy is still 20 years shorter than for their non-sickle cell affected compatriots. Now, what is up there in conventional therapy? Taylor nicely summarized it in Blood 2016. We can manipulate several parts of the disease. GBT440, for example, is increasing the oxygen affinity and therefore maintains oxygen within the red cells. We have all measures like crizanlizumab, the P-selectin inhibitor antibody that avoids the adhesion of these cells to the endothelium, and the interaction of the red cell with the endothelium is one of the major epigenetic phenotype modulators of sickle cell disease, as we now learned. So a modulation of adhesion, modulation of inflammatory stimuli with canakinumab and other anti-inflammatory drugs, and inhibition of platelet adhesion, for example, could all be approaches that might be put into the chest to cure sickle cell disease. But the problem is, in the long run, we have so far no evidence of long-term efficacy on chronic organ damage. We still have a chronification of the disease. Patients do not want to go to their physicians for the rest of their lives. They want to have cure at the end of the horizon. And I think it is the same problem as with hydroxyurea. The compliance is decreasing with age, in particular in puberty, and even later on, they are just fed up. This might be one of the problems that we face even with these new and fancy drugs for conventional therapy. On top of it, these drugs are not cheap by far. So there's a socioeconomical burden that we all have to face with conventional therapy in the future as well. Could these drugs be a bridging therapy to improve the patient's health until they are capable of going for stem cell transplantation or gene editing? That is something we have to discuss in the future as well. Glutamine, another nice example that is really intriguing. It is a non-essential amino acid. It's a precursor in the synthesis of other amino acids, glucose and NAD. And in sickle cell disease, it showed that glutamine increased the NAD redox potential, decreased the endothelial adhesion, and decreased the resting energy expenditure with an improved weight gain. The consequence, in a nice study for licensing presented at the FDA, showed that in a randomized approach where glutamine was given in a 2-to-1 ratio versus placebo, reduced significantly the time to first crisis by approximately 30 days. So this is another fairly simple but seemingly highly effective drug with a low adverse event profile in order to avoid these crises for sickle cell patients and get them along, probably with also reducing the hydroxyurea use or in combination with hydroxyurea for those patients who still have crises under medication. Now, the next important question, who to transplant? And I think this is my very personal and biased approach, is that sickle cell disease is worldwide, together with thalassemia, the largest group with an indication, an absolute indication for an allogeneic stem cell transplantation or in the future gene therapy. Outcome priorities. Now, when we talk about transplantation, most of us come from the field of transplanting leukemias, MDS, and other malignant diseases. And in malignant diseases, the message is straightforward. We do not accept the mixed chimerism. Absolutely not, because mixed chimerism is equivalent to relapse. Do we accept a certain level of GVHD? Sure, of course. We all like GVHD because it's going to give us some GVL and the patient is cured. But how much GVHD do we accept? And we all know if you open the Pandora's box, disaster can be hiding behind the corner. Do we allow DLIs to force a complete chimerism? Of course we do that, sure. We want the patient to be cured and get rid of his disease. And the donor hierarchy is clear. Matched sibling donor, at least equivalent to MUT donors and vice versa, nicely also shown in children in the Forum trial by Christina Peters, followed by 9 out of 10 mismatched unrelated donors, also very acceptable, and then cord blood or haploidentical transplantation, very well acceptable. In sickle cell disease, the question is cure for any cost. So, do we accept the mixed chimerism? I think yes, and I will show you data on that. Do we accept DLI to induce a complete chimerism? After what I just said, definitely no. Accept GVHD? I don't know. If yes, how much? Acute GVHD, grade 1 to 2 or more? Chronic GVHD, mild, moderate, or even severe? I don't think so. Do we accept rejection to avoid GVHD? I think this is a very tricky question. And we all have to answer this question for ourselves together with our patients, because nowadays the conditioning regimens are acceptable, toxicity is acceptable, that a second transplant within a short period of time is doable, and the overall survival of these patients is not bad. So instead of provoking a disease that we cannot control at all, to accept the rejection in these patients, to avoid GVHD, is definitely an option to consider. And for many of us, this is tough. Is donor hierarchy identical to malignant diseases? I don't think so, but we will see. I mean, this is classical, but for sickle cell patients, maybe the haplo approach followed by gene therapy or equivalent to gene therapy might outweigh the disadvantages of a blood donor transplantation. So, the burden of disease, and I think this is an important question. Several surveys among sickle cell patients have clearly shown that these patients are happy to accept anything. Even a transplant-related mortality of up to 30% is acceptable for a third of patients. Rejection, who cares, of course. Infertility, acceptable for over 50% of the patients. But mind you, very importantly, chronic GVHD was not acceptable for the majority of patients. I think we owe this to our patients to keep this priority in mind. Cumulative myeloablative stem cell transplantation for sickle cell disease shows excellent results in matched sibling donor settings for children with severe disease. More than 1,000 children aged 2 to 20 have been transplanted. The disease-free survival was up to 90%, rejection rate was less than 10%, and the transplant-related mortality was approximately 0 to maximum 12%. Incidence of acute GVHD, 10 to 20, chronic GVHD, less than 20%. So these data are excellent, but when we look at them in detail, nicely summarized by Barbara Capelli in Hematology in 2019, these excellent overall outcomes of 100% overall survival, event-free survival of 93%, incidence of chronic graft versus host disease of 9% were only achieved in patients between 0 and 5 years of age. So when we go to the right, 6 to 15, in particular patients beyond 15 years of age, the outcome is not as good. 88% 4-year overall survival, incidence of chronic graft versus host disease, 20%. So there is room for improvement. And that means we have unmet needs. There are adult patients with severe disease who have organ dysfunction are typically excluded from these excellent outcomes. On top of it, only approximately 10 to 15% have an HLA matched sibling donor. And on top of it, the question of MUD or haplo doesn't really pose a problem because not more than 20% of eligible patients find an HLA matched donor at all, including MUD donors. What if you wait longer? The problem is out there, and I'll show you this in a second, but there might be also some advantages. Number one, transplanting infants is associated with a high risk of viral activation and reactivation like adenovirus and CMV, and that is related with post-transplant complications, as we know. We have a far better controlled pharmacokinetic of our conditioning regimens when patients are older than 2 years of age, at least, and this is good. And an important message is here, you can ask your patient if you want to be transplanted or not. So you can ask consent instead of assent from a parent. And that might make a difference for the patients. And if the patients reach their age of 13, 14, 15, adequate fertility preservation, at least in male sickle cell patients, is quite possible. The downside is that about 12% of patients, or the mortality will increase by 12% if you wait more than 10 years. In addition, any delay in stem cell transplantation will increase the risks for immunization, hyperhemolysis syndrome, osteonecrosis, other irreversible complications like nephropathy, strokes, cardiopulmonary complications, and so on. Iron overload, and I think one of the most important and most neglected points is that patients lose school performance, IQ points, and execute functions. On top of it, the older the patients get into transplant, the transplant-related mortality is rising. Risk of VOD due to liver fibrosis, hepatic cirrhosis, and probably even hepatitis in some patients. The rate of graft rejection is rising in heavily transfused patients. PRES and other cerebrovascular complications are rising with age. And last but not least, there's a significant increase of chronic graft versus host disease in older patients. Now, Who is the best alternative donor? Is our donor hierarchy identical to malignant diseases, matched sibling, MUD, and 9 out of 10 MUD? We will see. Here is a nice series of pediatric patients. So we're talking about young patients, not at a high risk for graft versus host disease, published by Shelish-Shenoy in Blood 2016. 30 children and young adults, 4 to 19 years. Very straightforward conditioning, campus flu mel, not really toxic in the end. We have a nice GVHD prophylaxis, calcineurin inhibitors, short course of methotrexate and prednisolone. The results are a disaster. Event-free survival at 2 years of age, 68.6%. Overall survival, 79%. Acute GVHD grade 3 to 4, 33%. Chronic graft versus host disease, extensive, 38%, with 7 GVHD-related deaths, 23%, and a graft rejection rate of 10%, and a press rate of 34%. The consequence was swift and very remarkable, that all the conventional hematologists in the UK replied that if this is what you do with these patients, you should stop doing transplantation and sickle cell disease. Rightly so, I would say. Now, here, recently published by Mary Epen in Lancet Hematology 2019, the US experience from the CIBMTR registry, 910 sickle cell patients transplanted between 2008 and 17. So it is a fairly new series of patients, 558 matched sibling donors, haploidentical transplantation with post-Cy, MUD, and mismatched unrelated donors. The outcomes are depicted here. Event-free survival in haplo post-Cy, 49%, graft failure, 38%, overall survival, 64%, and chronic GVHD, 27%. Not much different from the MUD donor setting, 69% event-free survival, 3-year overall survival, 82%, not brilliant at all. And when you compare these results with the matched sibling donor transplantation of 96%, there is a difference. So MUD doesn't look like it is equivalent to matched sibling donor transplantation in sickle cell patients. We can ask ourselves why this is the case. And I think we might find an answer when we consider that sickle cell disease is a disease of an activated endothelium, of a chronic vasculopathy. So it's a high-pitched, potentially active endothelium with an inflammatory environment. And if you add an allo transplant setting to this, you probably will face more problems than you would in a matched sibling setting, or probably also even in a T-cell depleted setting. But this needs to be proven prospectively. Good. Now, here again, these results, event-free survival, graft failure, and overall survival, there are not much difference here, but of course, all three of them, haplo, matched unrelated donor, and mismatched unrelated donor compared to sibling, all fare significantly worse. Now the analysis from Elian Gluckman in 144 patients, EBMT experience, again, haploidentical or MUD donors. We had 144 patients, as I said, from 30 centers. Unrelated were 76, haploidentical related were 68 patients, so 47 and 53% respectively. Stem cell source was mainly bone marrow, median age at transplant 11 years, so these patients are fairly young again. The conditioning regimen, surprisingly, first in place flu trio thiotepa with 46%, and ATG was a predominant in vivo T-cell depletion modality that was used. Here are the Kaplan-Meier curves. 3-year overall survival, comparable between MUD, haplo post-Cy, and T-cell depletion. Event-free survival, also fairly similar. Acute GVHD, day 100, 25% in MUDs, 18 in post-Cy, and T-cell depleted haploidentical transplantation comparably at 23%. Chronic GVHD, 24, 21, and 14%. So here is the difference that we see with post-Cy MUD versus ex vivo T-cell depletion and haploidentical transplantation of these patients. And this might be an advantage for those patients here. Now, compared to these retrospective series, I want to present you now data from single center experiences or prospective experiences in haploidentical donor stem cell transplantation. Number one, the Vanderbilt Consortium where they set up a prospective trial with post-transplant cyclophosphamide, fludarabine, cyclophosphamide, thiotepa, and thymoglobulin with the conditioning regimens, followed by 200 centigrade of TBI and post-transplant cyclophosphamide. Immunosuppression was with sirolimus and MMF. And this is the series in the setting in the UK, nicely and kindly presented to me by Jose de la Fuente from St. Mary's in London. 23 patients received the preconditioning and 10 patients were not preconditioned. The preconditioning consisted of azathioprine, hydroxyurea, and hypotransfusion. The outcomes are depicted. Graft failure, 13% with preconditioning, none without preconditioning. Acute GVHD, grade 2 to 4, 13 versus 50%. Chronic GVHD beyond day 100, extensive, 21% versus 40%. Chronic GVHD at 18 months resolved in all of the patients. The mortality in the preconditioning of 21.4 and 21.7% due to macrophage activation syndrome. The incidence of TMA was 8% versus 30%, and MAS was observed in these 30%, 7 patients versus 1 in the setting with no preconditioning. Now, the question that arises here is, what is the difference between preconditioning and not? The intention was basically to calm down the bone marrow, to allow engraftment, to reduce myeloproliferation. But I think what was achieved is that these patients, or rather the donor cells, fell into this immunosuppression that was still ongoing and bypassed the cyclophosphamide radar post-transplant. And in combination with any form of inflammatory trigger, be it viral or anything else, in a patient with an by nature intact immune system under immunosuppression, there might something occur that we would call immune dysregulation leading to macrophage activation syndrome. In the end, we have no idea why this is the case, but we have to keep an eye on it, and I think we will face more of this, what I call new veno-occlusive disease, transplant-associated microangiopathy, because these patients will come up, and we will transplant more patients with a haploidentical approach. So we have to keep an eye on that, and I think there's a point of no return where we can do whatever we want. If we don't stop the triggers, we will lose those patients. On the next slide, we see our series here in Regensburg. It was a combination of patients that were transplanted in Regensburg, and 5 of those patients were transplanted in analogy to our protocol in Berlin. Altogether, we transplanted 33 patients in a direct comparison, 9 matched sibling donors and 24 haploidentical donors. And median age was 14 years, so we had patients that were fairly old, up to 25 and 31 years. Median follow-up was approximately 2 years, and these patients suffered from fairly advanced sickle cell disease, acute chest syndromes, alloimmunizations, osteonecrosis, and so on. The conditioning regimen is depicted here. Flu trio thiotepa was the backbone. For the matched sibling donors, ATG was given conventionally. The graft was a bone marrow graft on day -3 to -1. In patients that received a haploidentical transplantation, we used ATG graft alone at a different dose. That is also important, 50 milligram per kg versus 10 in the matched sibling donors, and we used it upfront prior to conditioning. Treosulfan was chosen particularly for 2 reasons. Number 1, treosulfan does basically not pass the blood-brain barrier and does not therefore be a trigger for systemic vasculopathies cerebrally affecting sickle cell patients in the form of PRES. And on top of it, we know that compared to busulfan, treosulfan is a drug with a significantly lower risk of endothelial toxicity leading to veno-occlusive disease and other post-transplant vasculopathies. As an immunosuppression post-transplant, and this is also an important part of the conditioning regimen we used here, we used cyclosporin A and later on switched to tacrolimus because we observed significantly lower incidence of neurotoxicity using a continuous infusion of tacrolimus in combination with MMF. So while we use the immunosuppression for avoidance of GVHD in the metastatic donor setting, the prolonged immunosuppression, as you have seen here, beyond day 180 for the haplo setting, was used to avoid rejection primarily. Most important slide here, overall survival 88% versus 100% in the metastatic donor setting, disease-free survival 88%. Over the last 8 years altogether, we had 3 fatalities. 1 patient developed a CMV pneumonitis and succumbed to an acute respiratory distress syndrome. He was a no-show for a couple of weeks, and when he then showed up, we had no chance to cure this patient. So the consequences we are drawing now is that patients with a CMV mismatched donor and recipient, we use prophylactically letermovir, and so far had no problems with that. 1 patient we lost due to a major ABO incompatibility and late graft failure. So from now on, none of our patients will receive a graft from a donor with a major ABO incompatibility. It's a consequence here, and we're currently investigating in a retrospective series within the EBMT registry if this is true for other sickle cell patients and immunoglobulopathies. And 1 patient also was lost due to diffuse alveolar hemorrhage / macrophage activation syndrome in the setting of CMV activation and immunosuppression. And this is the only patient where I cannot offer you any solutions. That's something that you really have to avoid. Chimerism of immunosuppression, very important. I will get back to that in a minute. Was 99% and 98% respectively in both sets of patients. The incidence of GVHD, very important information here. Acute GVHD incidence 29% and 33%. This acute GVHD was only grade 1 to 2, means we treated these patients with steroids for 3 to 4 days, mostly 7 days, and it was gone. And chronic GVHD, mostly predominantly in the older patients and adult patients, was 8% and 11%, and it resolved in almost all patients by 18 months post-transplant. Now, based on these excellent results, we're now engaging in a prospective stratified non-inferiority phase 2 trial, where we stratify patients who are eligible for stem cell transplantation in 2 groups. Those patients who have a donor will receive a metastatic donor transplantation with a conditioning regimen that I've shown you before. The stem cell sources, bone marrow, immunosuppression is MMF and tacrolimus, and the weaning is chimerism trigger. On the other arm, arm A, the experimental arm will be a alpha beta T cell depleted haploidentical transplantation. Again, with the same conditioning, just with the difference of the use of ATG up front here. The same immunosuppression prolonged. The primary endpoint is a composite endpoint, disease-free and GVHD-free survival in these 2 patient populations. And the assessment of GVHD will be centralized with a biopsy-driven pathology reference reviewed by a panel of experts for liver, skin, and gut. And the trial will be an international trial, and I hope we really can show that a haploidentical TDP stem cell transplantation is at least not inferior to a metastatic donor transplantation. The question we have to ask ourselves now is, why are the outcomes in retrospective collective data from registries, EBMT or CIBMTR, what we now call real-world data, so significantly worse compared to any prospective approach? And just for this presentation, I extracted from the EBMT registry 915 patients who were transplanted for sickle cell disease between 2008 and 2018. And we found 34 different conditioning regimens. 34 different conditioning regimens, and that's only one difference to prospective approaches, controlled approaches with a proper plan and an aim. The good message here, I don't want to depress you at this late hour, is that 75% of the patients receive either busulfan or flutriafotop, 25.3% of the patients. So I think we can, in the end, harmonize the approach for the conditioning, either with busulfan or with flutriafotop in those countries where it's currently available. Now, I promised you a word on chimerism, because chimerism in sickle cell disease is something of utmost importance. Here's a nice publication in 2019 in Hematology by Marina Cavazzana. They looked at 34 patients transplanted from matched donors, matched sibling or matched unrelated donors, and evaluated them because they developed a mixed chimerism. They needed a 12 months follow-up to be included, and they clearly showed that there's a selective advantage of donor red cells, despite partial engraftment of other lineages. The donor engraftment was lower for T cells than for other lineages, except for patients with the lowest chimerism. And the myeloid, rather than the T cell engraftment, was the key efficacy criterion. And a myeloid chimerism as low as 30% is sufficient to prevent sickle-related vaso-occlusive crisis in patients who had a donor who was healthy, in contrast to patients who had heterozygous sickle cell donor. And the correction of hemolysis requires a higher donor chimerism of above 50% in both donors, AA and AS. So this is an important message, not only for stem cell transplantation, but also for gene editing. So at least 30, respectively, 50% of donor chimerism or expression of edited cells. And this is something we have to keep in mind, and we have to confirm prospectively. What does it look like in clinics? Now, this is a patient from our series. The total chimerism in this patient at day 250, in this case post-transplant, was approximately 57%, if I remember correctly. The T cell chimerism was even lower, 23%. But in the end, the myeloid chimerism in this patient was 100%. What did we do? Nothing. So the message is, in case of a mixed chimerism, very important, take your own blood pressure first. This is evidence-based since 1978. Number two, do not stop immunosuppression. Means if the patient is on immunosuppression, you started weaning the patient of immunosuppression, and you see that the chimerism that you hopefully do on a weekly basis, total chimerism, is falling. Restart him back on the last level of immunosuppression, the last dose, keep him on that for another 4 to 6 weeks, and restart weaning him. No DLIs. And most importantly, if you do transplant patients with sickle cell disease, you should be able to evaluate a split chimerism in these patients, because you will see that the majority of patients who develop a mixed chimerism will develop something that we call a dissociated split chimerism. So the chimerism is 100% in the myeloid lineage and probably less than 50, less than 30% in the T cell compartment, which is absolutely acceptable, particularly in patients who receive a haploidentical transplantation, and there in particular patients who received a T cell depleted haploidentical stem cell transplantation. We have not lost a single patient with this approach due to rejection, and it is an approach that requires the access to a split chimerism analysis, and it will help you really to make your decisions properly. Last but not least, gene therapy and gene editing. There are the results by Julie Cantor on the Bluebird bioproduct presented at IACH 2019. They currently enrolled 25 patients. Cell collection was pending in 3 were ineligible, so there were 19 patients who received the plerixafor mobilization, and 2 patients were discontinued, 16 patients completed the manufacturing, and in the end, 13 patients were infused. And here is the approach to the lentiglobin gene therapy product. Patients are mobilized with plerixafor, and the good message here is there were basically no to very little adverse effects after plerixafor mobilization, and the mobilized cells are then centrally manufactured and transfused with a BB305 lentiviral vector. The bad message here is, yes, of course, these patients need also myeloablation, and in this case it was busulfan. So they received the busulfan conditioning that is, as we all know, associated with loss of fertility in those patients. After the myeloablation, these patients received the lentiglobin product as a normal infusion, and the engraftment was observed later on. These are the results. We have a total follow-up of 15 months overall in 1 patient, and the median hemoglobin in those patients is rising from 10.7 to up to 15%, and at the same time, also the level of gene edited or gene manufactured product, the hemoglobin A T87Q, is also on the rise from 33 to 59%. And at least in this one patient, the most successful with the longest follow-up, there is a persistence of 40% of sickle cells. And important is to see what's going to happen with the majority of those patients. If they remain at the 50% level, it might very well be that the problems with chronic vasculopathy, hemolysis, and affection of systemic vascular-related complications like heart, lung, and kidneys might show up maybe 10 years later, but this is one of the risks that we have to see. Of course, we need more numbers, but overall, the results are really impressive for now. Clinically, the sickle-related complications like acute chest syndrome and serious renal occlusive crisis cease post-transplant, so there's nothing anymore, at least in these 6 patients, but we have to see. We need a longer follow-up, we need more patients, and we're really eagerly expecting the results of the ongoing trials. The next approach, very modern, very popular, is a CRISPR technology-based approach to transplant sickle, to treat sickle cell patients, patients with beta thalassemia. The approach here is different. It's a gene editing approach. CRISPR-Cas9 is used basically to knock out BCL11A. With a knockout of BCL11A, the suppressor of fetal hemoglobin is removed. And after an effective gene editing, patients start to produce fetal hemoglobin post-gene editing. So that's the idea behind it. In vitro, it could be shown that most erythroid colonies express high gamma globin mRNA levels, so up to 75% of the colonies express biallelic edited colonies, which is good. Also, the edited cells maintained the ability to engraft and differentiate. And we have so far 2 patients who received the product, 1 thalassemia patient and 1 sickle cell patient. And unfortunately, at this moment, there's no new information I can give you on these patients, but you should look out for one of the upcoming hematology meetings at ASH, EBMT, or EHA, where you might get more information on this very exciting topic. So conclusion for sickle cell disease, conventional therapy. There are definitely major advancements within drugs. So it's not only hydroxyurea. We have to keep in mind that there is an increasing body of evidence that sickle cell disease is a precondition for AML and MDS. There are publications out there who show that their risk to develop a myeloid disorder is higher than the general population. How high this risk will be with a use of hydroxyurea starting in infants is something that we have to keep in mind. The outcome with regard to chronic vasculopathy with conventional therapy is unpredictable. Yes, you might reduce the risk of vaso-occlusive crises, acute chest syndrome, all the classical sickle-related complications, but is a chronic vasculopathy shut down as well? As far as we know so far, with hydroxyurea alone, probably not. So we have the problem of the chronification of disease associated with the low compliance, and that is not good for the patients. With the new drugs, we have the problem of an ongoing high socioeconomic burden, but I think that's something that we have to live with any of the new drugs and treatment options that we have to have available today for many diseases. An advantage definitely is if you can reduce hydroxyurea-related complications, achieve optimal conditions for before we implement any form of curative option. So this might be the slot where conventional therapy fits in perfectly, modern conventional therapy as a bridging therapy, achieving a patient or getting a patient in the best condition prior to stem cell transplantation. Alternative donor stem cell transplantation. Well, matched-indolent donor stem cell transplantation is a standard of care. Age is a question. I don't know if I would transplant a newborn or an infant with sickle cell disease who never showed any sickle-related complications, because there's still the risk of mortality. And in the end, we have to tell the patients that a presumably healthy child who could have developed sickle-related complications at age 15, 17, or even 20 now is in trouble. Haploidentical transplantation is curative for almost everybody, and is increasingly safe. And haploidentical transplantation, in particular with post-transplant cyclophosphamide, is cost efficient and therefore also affordable in low and middle income countries. I think sickle cell disease is a disease that can challenge the classical donor hierarchy. Matched sibling, mud, haplo, or is it rather matched sibling, haplo, mud, or nothing at all after haplo? It is something we have to keep a close eye on if, in particular, graft versus host disease will make a difference between mud and haplo transplantation. And as I've shown you, prospective controlled trials with a smart approach are pivotal for these patients rather than collective data from registries, because they do not really reflect what is possible in 2019 to cure and help these patients. Gene editing, definitely very sexy, very attractive. We have no donor problem at all. No GVHD, no rejection, no problems with immune reconstitution. Of course, it's still experimental. We have just treated a handful of patients and it's not widely available. One of the major bottlenecks is the lab manufacturing. So, even if we had 1,000 patients who can go into trial, currently we have no slots for these patients and the waiting period is quite long. We have always, with any form of gene editing, the risk of insertions and deletions, indels, and of target effects. And we have seen that in the 70 patients that were treated with the Bluebird Bio product, there was one patient with MDS. There's a publication by Karan et al. Coming out on thalassemia, where they showed that there's no transplant-related secondary malignancies in TEL, and 1% out of 294 patients in sickle cell disease. And even if the vector was not found in this one single MDS patient, if a second patient shows up within the next 50 to 100 patients, I think we have to look very carefully what is going on there. And this is, of course, not limited to lentiviral approaches like the Bluebird Bio approach, but it can also happen with CRISPR-Cas, TALEN, or any other gene manipulating approach that we have to face in the future and have to keep a close eye on. Gene silencing and insufficient expression, as I have shown, could be a problem if the expression of either hemoglobin F or the modified beta globin chain is not high enough. These patients, at least in extreme situations, as we already know from the heterozygous setting, will suffer from sickle-related complications. These are surrogate therapies. They are, I think, perfect for thalassemia with more than 300 mutations, but in sickle cell disease, we have a point mutation. So the future might be gene editing with homologous recombination when effectively applicable in mature stem cells, and this is something that we have to wait for. Of course, just as it is a problem in haploidentical transplantation, there's a loss of fertility, and we will have in the future the opportunity to do non-chemotherapy-based myeloablation, but it's not yet available mainstream. And of course, one of the major problems with gene editing are the costs. Bluebird Bio asks $1.8 million for gene therapy, and I think this is not something we can apply in low and middle income countries, but I think we cannot even apply it in high industrialized and rich countries such as Germany, UK, or probably even in the US. So gene editing is at the moment, if available, limited to a population of sick patients with no donor at all. I think this is a perfect population for gene editing. And for the remaining patients who have no matched sibling donor available, haploidentical stem cell transplantation is definitely a choice. We should not wait too much longer. We should engage in prospective trials. We should open prospective trials to really compare their capabilities and downsides. And it is our duty to offer a safe and efficient curative option to patients with sickle cell disease. Thank you very much. And I'm now open for any questions. I'm happy to answer. Thank you. So let's see. So question number one, Is there a difference in transplant procedures and principles between transplant sickle cell disease versus transplant and thalassemia? An excellent question, very important question. I mean, when we look at transplants in thalassemia, the risk of rejection is significantly higher. In particular, late rejections are something that we observe with sickle cell, with thalassemia, but not with sickle cell disease. But I can tell you we have done 5 patients with exactly the same conditioning, haploidentical transplantation and thalassemia, advanced stage elderly patients who all have survived with no GVHD and no rejection. So I think in the end, if you can prove that in a larger series, the answer is probably no. At the moment, yes, there's a difference. In sickle cell patients, we have to watch out for all the vasculopathies. So there, the choice of conditioning, as I've mentioned, is important. Next question is sickle cell stem cell more resistant to chemotherapy than the leukemic stem cell, like the situation in thalassemia? No, it's not the chemotherapy. I mean, fluotriotepa, for example, is a well-tolerated conditioning regimen with low to really no toxicity in many patients, and it works extremely well. It is the risk of rejection, again, that makes a difference. Leukemic patients do not reject their graft post-transplant. Sickle cell patients do, and more so, of course, patients with thalassemia. Question number 3, is thalassemia not recommended to transplant below age of 1 year? As I said also, I would not transplant a sickle cell patient nor a thalassemia patient below even 2 to 3 or even 4 years of age. The iron overload in these patients is still not so advanced that we have a major problem or an irreversible problem later on. So a successful stem cell transplantation in thalassemia at age 10 years with an adequate and extensive iron depletion post-transplant via phlebotomy, for example, is safe and has no problems and restores these patients ad integrum without any complications. And in sickle cell disease, it is not the genetic background that is important, it's a clinical presentation. Sickle cell phenotypes differ within families significantly. So there are 2 SIBs. One SIB develops severe problems starting at age 3, whereas the other SIB has no problem up to age 15, 16, 17 years, and little by little starts to get pain crises. So unless the patient presented ever with a sickle-related complication, I would not go for transplant. And this situation emerges only in parents who lost one child, one SIB, due to sickle-related complications. So those are who come immediately post-delivery and say, okay, this patient, if this child develops sickle cell disease, or if we have a genetic proof of sickle cell disease, we want an immediate transplant. And that is a difficult situation for the physician. Is there immune effect against sickle cell? Well, immune effect, I don't know what it means, probably immune effect like a graft versus sickle cell. I don't think so. I think it's a straightforward myeloablative transplantation where we need a strong immunosuppression, at least in T-depleted haploidentical transplantation, to get the graft in, but otherwise an immune effect is not really necessary. Is there advantage of transplant versus gene therapy in sickle cell disease? Well, I mean, for those who have no donor, it's clear it's gene therapy if you have access to it. Otherwise, I think a stem cell transplantation has advantages over gene therapy. We know what we do. We have transplanted millions of patients so far, everywhere. We know that these grafts stay in. If they're in, they're in. And we know all the adverse effects that these patients are facing, even in non-malignant diseases post-transplant. So we can offer the patient a portfolio with a fairly well-defined risk profile. And in gene editing, we cannot do that. We cannot really say, will the graft stay in, the edited graft? Do we have any adverse effects at all? Do we develop secondary malignancies after the graft? There is little known so far. That's why we really need the trials and really need these answers in order to answer this question properly. Okay, that is it. Thank you very much. Bye-bye. Have a good evening.